Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. I want to start by thanking everyone for the amazing feedback I received after airing last week's episode with Dr. Amanda Vanderstelt. I was truly humbled by many of the comments, and it only motivates me further to bring you valuable content that can help you succeed both personally and professionally. And we're going to continue with that with today's guest, Dr. Andrew Leland. Andrew is an orthodontist who owns and runs a practice in Reno, Nevada. He completed his undergraduate studies at Santa Clara University, where he graduated with a Bachelor of Science in Mechanical Engineering. He then went on to attend dental school at UCLA and complete his orthodontic residency at the University of Texas at Houston. During his time in practice thus far, Andrew has embarked on a journey which may sound familiar to many of you out there, as he's gone from being a more traditionally trained orthodontist who focuses on reactively straightening teeth to one who looks more at the etiology of malocclusion and tries to proactively address the aberrant craniofacial growth and development of younger patients. This includes looking at CBCT images of airway of all of his patients and taking a more aggressive stance on early interceptive orthodontic treatment. Some of what we discuss on today's show includes Andrew's unique journey into the field of orthodontics, when and how he realized that he could do more than just straighten teeth, including the involvement of the orthodontist in both airway and its role in aberrant craniofacial growth and development, his approach to the diagnosis and treatment of younger patients, the need to constantly evolve and learn, both personally and professionally, the challenges associated with balancing the roles of dad, husband, business owner, and orthodontist, how your mindset impacts the ultimate result of everything you do, and much, much more. In addition, if you know someone who could benefit from hearing the content of these episodes, please share the show with them. Also, if you feel we've earned it, we'd love to receive a 5-star review on Spotify or Apple. And don't forget to subscribe to the Doc YouTube channel as well for more great content. I'll be sure to put a link to that in the show notes for today's show. So without further ado, let's get to my conversation with Dr. Andrew Leland. Enjoy the show, everybody. Welcome to the Doc Podcast, Andrew.
Thank you, Mike. Excited to be here. Thanks for the opportunity to be on.
Yeah, no problem. Really excited to have you here and have this conversation. As I say so often, but I love hearing the background that brought people to the point that they're at, that journey that they go on, and really enjoy starting the show with getting to know my guests a little better so that the audience can hear their journey and talk a little bit about where you got to be the Dr. Andrew that you are today. So if you can give us that overview of your upbringing and path to becoming an orthodontist, and then a little bit about what's brought you to this point in your orthodontic career, that'd be great.
Yeah, absolutely. So I have a bit of an unconventional path that way. Didn't grow up knowing I wanted to be an orthodontist. Didn't think of being a dentist ever, let alone orthodontist, till probably about age 25. So won't go into every little detail, but I grew up, I love math and science, and I ended up studying mechanical engineering in college. Really enjoyed the theory of that, didn't enjoy all the equations and the extensive math, and I wanted to work with people more. So had a couple offshoot careers after college trying to figure out what I wanted to do, and those weren't it. And reached this point where I'm like, all right, clean slate. I'm not going to spend the rest of my life doing something that I'm not happy with, not fulfilled by. And so I started looking into anything that I thought would be interesting. Looked into everything from being an orthopedic surgeon to a pilot to actually the funniest one's an actor. I took an acting class, and that wasn't going to be it. But one day I've tried a bunch of things. I'm willing to put in the work to be whatever I'm going to be, what I feel like I'm going to be fulfilled by in the end. And one day my wife mentioned dentistry. She said, have you ever thought of being a dentist? She has a brother who's a dentist, and her mom was a hygienist. So it runs pretty deep in her family. It doesn't really in mine, but I thought, that's interesting, and looked into it. And then I shadowed a dentist, a general dentist down the street for about 6 months, a couple times a week. I just did some volunteer work there to see what the office was like. And it went from there. And then for me, going to dental school was a big deal. I was going back to school. I had to take community college classes for about a year to get into dental school.
So how long was your gap? I'm sorry, how long before you went back?
The gap was 5 years. So
oh, wow. That's pretty big.
I graduated undergrad, never for a second thinking about being a dentist. Not
Wow.
for a second. But I tried 3 different careers that are offshoots of mechanical engineering, like jobs I could get with my degree that were different than that. Because I had this sense I don't want to be a traditional engineer, and those just weren't it. So ended up going to dental school. Like I said, my wife put me in the direction of that, and once she did that, hey, that was a real smart direction to point myself. And then
Mm.
once I got into dental school, believe it or not, if you would have asked me at the start of dental school, what are you not going to be? I would have said, I'm not going to be a pediatric dentist or an orthodontist. And
Really?
I knocked the first one out of the park. No offense. I love the pediatric dental community. It's just not me. But orthodontics, I thought it was like the engineering form of dentistry. And like, we're going to be doing a bunch of calculations, a bunch of equations, a bunch of that kind of
Hmm.
stuff. And I also thought it was just extremely aesthetically driven, which is probably ties into what we're talking about, the overlying theme of Airway here on this podcast, which I love. But I saw the difference you can make in someone's life when you enhance their smile and when you
Mm.
make them confident in how they appear. And so when in dental school, I decided to go into ortho, and that's got me here.
Wow. And then did you start out working for someone right out of residency? Did you, you own and run your own practice now in Reno. How did that happen? What was the trajectory like once you got into the profession?
Yeah, another good question. So we looked into moving to a few different cities, looking for, like we probably all do, the balance of a place we'd like to live with a good practice opportunity. And I
Hmm.
went into practice. I had a job with another orthodontist that honestly, as soon as I stepped in the door, our ideologies just didn't align. And
Hmm.
that's okay. There's different ways
Hmm.
to practice, but the
Yeah.
idea
Yep.
going there was that was going to be long term. And very quickly, that was apparent that it wasn't going to be that way. And I looked around at the community, never really thought hard about starting a practice, although I'm very entrepreneurial that way. So I wasn't put off by it. But I thought there's nothing to buy and I want to own a practice. So here we go.
Mm.
We're starting. And I felt like the community could support another practice like with the vision that I was trying to build. So it worked. And honestly, it's worked out great. I'm super grateful that it went this way. Not easy by any means, but it's
Mhm.
been an amazing journey so far.
And you're about 6 years in to your own practice?
Exactly. Yeah, we just passed the
Mhm.
6 year mark with my practice. And I left out, I had an associateship while we were physically building out the practice, a different associateship than the one that I originally
Okay.
went into,
Mhm.
also in town here. And that one I was at for about, well, two actually. That one I was at for a year and a half. And then simultaneously, I was going to a town called Elko, Nevada. You can look it up on a map. Northeastern Nevada
Hmm.
is about 300 miles away. I would go there twice a month
Whoa.
for 3 years. And that was like a gateway thing where I could go there, I could serve the patients there. They had a hard time getting orthodontists out there, so the compensation was really good, which is great when I was starting my own practice because you do a lot of work and you don't make much money at first. So
Mhm.
those
Yep.
two combined helped get me off the ground.
Since you have had that combination of associateship experience and practice ownership. You know, I only had the practice ownership side. I literally within a week of graduating UConn, I opened my doors. So when the residents ask me and when docs I help, younger docs ask me for advice on what they should do, one thing I tell them is everybody's situation is different, right? Like you said, I mean, it's where are you going to live? What's your family situation like? You have kids, you not have kids? What sort of time do you want to dedicate? And as I say a lot on this show, what's your vision? That being said, if somebody is thinking maybe they do want ownership, right? Because I hear that a lot from residents. They'll say, yeah, eventually I want to own my own, but I'd kind of like to work first for someone. Could you give some advice or some insight into that on what you would say to those younger docs about that process and that journey?
Yeah, I would first say that I think there's a shift that needs to happen between the student and the practicing orthodontist. And that's
Mhm.
that when you get out of school, you're allowed to think for yourself and do what you want. And I know that may sound trite, but in school there's not a whole lot of choices. I mean, obviously we're our own people, but you got to follow the paradigm and you got to go with what they're
Yep.
giving you. When you get
Yep.
out, you really can skin a cat multiple ways. You
Mhm.
can work as an associate your whole career if things like payroll and HR issues and ordering and leasing a space and all those things that come along with ownership, if that sounds horrible, and you like working clinically as an orthodontist and you plan on doing that your whole career, hey, consider that. That's not
Hmm.
bad. But if you want options mid later career, meaning like yourself, Mike, I mean, you decided to go a different direction and support that. And I don't want to speak for you, but I doubt that would have happened if you only associated the whole time. It just doesn't seem like that would have been possible. If, what I mean by options too is if you want to work 2 days a week, if you want to work 3 days a week, if you want to work
Hmm.
half days, if you want to pack more into a schedule and work really intense, shorter hours, if you own,
Hmm.
you can make it happen. And I think
Yep.
ortho in particular allows for that variability in business processes that probably endo, oral surgery, other things like that. I've never been one, but I don't think they have that type of business variability. So
Hmm.
what I would say to residents is really do it for the right reasons. Don't just say, I want to own because I want to make more money. It's like, that's fine, but do you want that lifestyle? Because you are going to have to, you're a business owner. You're going to have to deal with everything that goes along with it. Some love that. I happen to love the business side, a lot of it, not
Hmm.
all of it. But know that you're doing it for the right reasons. And if you do want to own, which many of us do, and I fully support that, it's going to be a leap to either buy in or start one. It's gonna
Hmm.
feel like this is too much. Like that, I'm not sure I can handle this. That's what it's gonna feel like. And although I'm not an advocate of overspending and just building the Taj Mahal practice right off the bat or something like that, do be willing to take a leap because I believe that's
Hmm.
what it's going to take when you would go from a non-owner to an owner in pretty much any capacity.
That's great advice. And you're 100% right. I couldn't have done what I did without, if I was an associate, I guarantee it. And I love that you mentioned that it's important for them to be able to recognize what they're going to have to deal with and not just do it for the money. Because so often young docs, especially today, are coming out with a lot of debt. They have a lot of bills. They want to expand their lifestyle a little bit, which I understand. And they know that in the end, practice owners tend to make more money than non-practice
Oh,
owners do.
absolutely.
And so, but it's really important that they figure out what they want. And I echo exactly what you just said. And I tell them that a lot. I say, ultimately, you've got to figure this out because if you're a practice owner and you don't enjoy the things you talked about in practice ownership, or if a toilet clogs, or there's an electrical issue or a plumbing issue or an IT issue, you don't have 24-hour plumbers, electricians, and IT people in your building most of the time. So you've got to be able to run between seeing a patient and run and try to fix this or do this. And that's just the nature of it. If that's not you, better know that early rather than later and find out what your lane is. But that being said, the follow up to that, which I also love, is if it is you or you think it may be you, don't keep putting it off. Take that step when you don't just keep, well, eventually, if you know that's your vision, you got to move in that direction.
Totally agree. I think ownership is much more of a slow momentum play. It takes a
Mm,
long time to build up that momentum, or not a short time. But once you build up that momentum, man, you're in a good spot if you're happy being that person. And I couldn't imagine doing it any other way personally. And also on that topic, it's a momentum thing. When you have a practice, even if you're doing well, you're going to continue to have to fix stuff. You're going to have to continue to
mhm.
make decisions. You're going to have to continue to be the leader. So if you're kind of like, I can do that for a short time, I'll get this thing up and going and see what happens. It's like, be weary of that. You got to want to be in that seat for a significant period of time. But if you do, I think it's the best way to go.
Yeah, that's great advice. So you get in, you've got your own practice. Where was it in this process that you started to question some of those dogmas, question the paradigm that you said so accurately? And I agree. When we're in our residency, there's some free thought, but truthfully, not that much because you're just doing things that the faculty who are there with you basically tell you to do. You're at the mercy of their guidance and their instruction. And as many of us know out there, a lot of the faculty in a lot of orthodontic residency programs may never have done this in private practice. And I'm not blanketing all programs, some are different than others, but in a lot of them, a lot of the faculty members are people who have been in the academic arena exclusively or primarily for most of their careers. And they have one philosophy on how you're supposed to approach these cases. And I think you would agree with me, correct me if not, that a lot of programs and a lot of orthodontists are still being taught the traditional mindset that was taught decades and decades and decades ago. And that is this reactive, be the best tooth straightener out there mentality, right? How do you straighten teeth the best and reactively? You got out and you're a critical evaluator. You aren't one, much like myself, who needs to follow the pack and be doing it the way everyone does it to feel good. You want to challenge yourself and push, and you have the mindset to always try to do better and be better for your patients and what you're doing, which I love and admire. So at what point did those two things intersect where you had this mentality of your training and then you have this drive to be critical? Maybe your mechanical engineering background, right? You're thinking, you're trying to put things together in different ways and process this. I know a lot of people struggle with trying to reconcile that. So how did you handle that?
Well, I think one advantage I had through this process is I had that 5 year gap between undergrad and starting dental school. And
Mm,
during that period of time, I asked myself really hard questions like, what fulfills you? What do you want to do with your life? What way do you want to point your life?
mm,
And it was clear to me at the time what I was doing was not as I've expressed. That wasn't it. But it's easy to identify things that are not. A lot of times it's harder to identify what is. So I'm sitting there going, I am willing to work for what I want to do. The problem is, I don't know what I want to do at this point. That to the airway thing, it's not like I was going through dental school and residency with this conscious idea of I'm sitting in class going, all right, I'm going to take what they're teaching me and adapt it to make it even better. I wasn't thinking that, but now that we're talking about this, I think I had that base in the back of my mind that I always wanted to critically evaluate. I knew I could critically evaluate. As you said, I think one really good thing about engineering school is that's inherent. It
mm,
is not regurgitating in engineering school. Oh
mm,
my gosh. I mean, a problem set of 4 problems was assigned to take a whole week. That was all the homework you had, and no one could even get it done because it was so just
mhm.
intense. So I think that was built in from those things for me. But then what really happened, and another more concrete angle of this is in early 2021, I got a cone beam. And I'd
Mhm.
already been dabbling in upper and lower expanders. I do a lot of upper and lower expansion on
We're going to
kids.
come back to that in more detail,
Perfect.
but go ahead. Yeah.
Yeah, and I do. We'll come back to that in more detail, but I want to point out that the age is a huge part of this, and people leave that
Yes.
out a lot. Okay, but
Yes.
that's critical
Yep.
to making this work
Yep.
correctly, in
Yep.
my opinion. And when I got my CBCT, you can just see so much. You can measure widths of maxillary and mandibular bone. So even if they're
Mhm.
not in crossbite, the things they teach us to look for, you can recognize that both jaws might be narrow, even if they're not in
Mhm.
crossbite. You can get more objective data than just, all right, teeth aren't fitting, and you can look at a nasal cavity and you can make judgments on that. You can look at an airway, you can look at adenoids and tonsils. And that getting that CBCT, I didn't know what that profound impact it would have on me seeing these things. But when I
Mhm.
got it, I saw them. And I know you've said, and lots of people say, once you see it, you can't unsee it. And I agree with that.
Mhm.
And really, the impetus for all this was fitting teeth in. We saw in residency, we saw that one day they brought in like prehistoric skulls, or I don't know when the skulls were from, but they fit all the teeth. The arches were wide, way
Mhm.
wide. They look totally different than every kid pretty much that I see in my consult room today.
Yep.
And it just didn't add up. It's like, okay, the point is not that we extract 4 teeth on everybody. I don't think that's how this is supposed to go. And
Mhm.
so it went from there, and then it parlayed into learning about how the jaws affect the airway, and here we are.
That progression is interesting, and a couple things I wanna point out with that, then I wanna get a little deeper into the treatment side and that philosophy of expansion in the absence of crossbite. I feel the same way about what cone beam did for me. When I got one in 2014, it changed the way I think. I'm giving a lecture at Winds of Change, and one of the things I'm going to mention is I get asked a lot on if you need to. People say to me all the time, Mike, do I have to have 3D imaging to be able to be airway aware, do anything relative to airway? And I say to them, okay, you don't have to, because there are other clinical signs that you can become astute enough to recognize in some of these comorbidities. That being said, there's no way you can get a complete picture without it. And it facilitates that knowledge base and the thoroughness of your diagnostic procedures and protocols, which again, we're going to come to a little bit with how you approach that when you have a patient come in. The other thing with that is we are taught. And a lot of people who listen to my show or follow my content know this, and that I say this often, but if someone's newer to the show, we are taught in orthodontic residencies, the vast majority out there, and I would say, I'd be willing to say our AO and our governing bodies would stand by this, as I said, with most program directors, that it would be called, I've even been told, it's indiscriminate expansion to expand in the absence of a posterior crossbite. So much so that it's told that you just don't do it. It's almost malpractice, truthfully, is what we're taught. I've been told that, actually. Yet that defies all the science. It actually defies the literature too, but it defies the science. It defies the concept of normalizing anatomy and doing exactly what you just said. I'd like to say you could give them a pass and say, well, if they didn't have cone beam, they didn't know some of the things you just said. But even studies going back to when Schwartz and Kratzinger were starting to introduce lower expanders in the 60s and talk about the concept of expansion. I mean, obviously that was pre-cone beam. Going back before that, Bogue, 1913, was talking about expanding both arches to be able to normalize the growth and make more room to accommodate the permanent teeth, treating proactively. Holtzman in 28 had an article where he spoke. It was, I believe, his ABO board defense in front of the AAO. I think he had to do it that way, and it was published in the AJO. And it talked about the need to expand both arches. He called them the temporary arches, but to expand both the maxillary and or mandibular arch. So that's 100 years ago. Like, this isn't new. And so the fact that orthodontic residencies and our governing bodies have gone the other way, and even in '06, McNamara had a great article with O'Grady, Bichetti, and Frankie on this. Prospective trial looked at 66 patients, and some had upper expansion, some had upper and lower, some had none, followed them over 20 years, and concluded those who had lower and upper expansion had superior results in every parameter they looked at. Why in the world is this so pervasive in our profession that you are not to expand a lower arch? And if you disagree with me, that if you polled the program directors out there, the scientific council at the AAO, that you would probably get about at least 4 out of 5 that would say that you shouldn't be doing that. Correct me if I'm wrong.
No, I think you're probably right. I mean, I think it stems from a little bit of short sightedness. What I hear all the time is there's a suture in the maxilla, and that's what we're expanding. The suture in the mandible fused at birth, which I
Yep.
100% undeniably agree with, and so does science. So no one's disputing
Right,
that.
right. Not really debatable. Agreed.
And
Yep.
no one's saying that you're expanding, or I should say, I'm not saying that you're expanding a mandible like a maxilla. It's not the same
Right.
mechanism, it's not the
Thank you.
same goal. But that being said, there is still a fair amount of available expansion in the mandible, in my opinion, from uprighting lower posterior teeth. And the
Yep.
real reason, this is what I tell people all the time, this is what I say when I speak in things, is the main reason I expand the mandible is to get more maxillary expansion, to get more nasal cavity expansion. Because if you have dental compensations where they're not in crossbite and the lower posterior teeth are really leaned in lingually towards the tongue, you can't
Yep.
expand the maxilla that much before you're in crossbite. And I
Right.
realize there's non-orthodontists on here, but basically saying like, you can't put the upper teeth completely outside the lower teeth. That would be a crippling bite for the patient.
Yep.
So you can
Yep.
only expand the upper so much if you don't expand the lower too. And the upper expansion is what dictates how much nasal cavity expansion you get. So
Yep.
that's the way I think of it.
Yeah, I agree. I don't think it's very complicated when you think of it that way. And on a cone beam and a coronal slice, boy, I mean, can you see it? It screams at you when you look at that curve of Wilson and that caving in of the lower arch. And one of the parameters to scoring an ABO case is curve of Wilson.
Yeah.
So if you are going, like, the irony there just kills me. It's
Yeah.
like if you're going to flatten your curve of Wilson, you have to upright your molars. I was of the school of thought, especially being a UConn guy, where we're very big in the sciences and biomechanics, that you want your teeth over as much sound bone as possible. And what you're saying, when the mandibular body, when the body of base of that bone is normal in its width or wider than where the teeth are, because the teeth are caved in to meet this narrow upper jaw, where is the argument coming from that you don't upright those teeth, expand them? Again, dental alveolar expansion, uprighting, tipping. We're not expanding the mandible unless we do distraction osteogenesis, which interestingly, Gimeno has an article about, I think it was about in like 2011 around then, talking about actually going in and doing distraction osteogenesis in some of these patients to get more expansion. But by getting the mandibular arch to be the normal width, or as I say often, I steal from Jeff Rouse, that normalizing anatomy, Well, now you can go up and get the normal arch width of the upper. And there may be people listening who are saying, well, what's the big deal? Why do you have to normalize it? So, what would you say to them who say, well, why don't you just treat to where the bones are and make the teeth fit?
It comes down to airway, and also just
Hmm.
people don't want to have four buys extracted. I mean, I think that by normalizing anatomy, we can make space for all the teeth, and then the
Hmm.
airway is going to follow the arches. So,
Hmm.
of course, we want good, wide, patent airways as much as we possibly can. And I
Hmm.
think everybody wants all their teeth if it's reasonably possible. And getting
Right.
back to the way I look at this too, I think of 7 to 9 years old or so, and varies per patient. That's I like to call it the golden age of orthodontic development,
Mhm.
because that's when all the sutures are patent. That's when we can set the jaw bones in place that'll more or less stay
Mhm.
that way in this patient for life. Now,
Mhm.
I know myofunctional therapy plays a role, relapse definitely plays a role. It's not that simple, but we have this opportunity to get everything where we want it to go at that time, and that is golden. So that's why I do so much expansion on those young kids. I think it's valuable for their whole life.
Yeah, and the other thing I'll say about that, and then I want to get into some of your processes and protocols for how you approach that. The example I always give is the patient you gave, where you talked about the fact that they don't have a crossbite, but they have a normal width lower jaw, lower arches caved in, upper jaw is narrow. That patient we're taught, well, they don't have a crossbite. You don't treat the transverse. Or like you said, maybe expand the upper a little bit, but you're only going to get so much. You certainly don't expand the lower. Well, if that's patient A, and then you take patient B, who has the identical maxilla, identical, no change, but their mandibular arch is more in line with ABO standards and bone biology and forces of occlusion, meaning their teeth are more centered over the bone, nice and upright, no steep curve of Wilson. Well, that patient, of course, has a posterior crossbite bilaterally, right? Of course, you treat that patient because that patient has a crossbite. My contention is patient A has a more severe malocclusion than patient B because patient A has a problem in both arches and undoubtedly has crowding in the lower arch as well because of that constriction. So, that to me, for people out there who are understanding what we're saying, especially, and I appreciate you acknowledging that. I do have a lot of lay people that listen to the show as well. That's what we're saying is it's this sort of compensation of the lower to this deficient upper, and that's why we're having this debate, and why you and I both, I think, can safely say have no idea why that's controversial. Um, as far as doing it, how do you handle it? Because I get a lot of feedback from people that when they do have the philosophy you or I have, and I face this in my own practice for sure, it's part of what motivates me to go out and teach this on the level I do. How do you help those parents? Because now you're telling parents you're going to do a lot more at a younger age than a lot of people. They might go for two other opinions, right? And they're like, oh, watchful waiting, or we're going to pull some baby teeth and let the adult teeth in the front try to find their way and then take them down that path. Maybe a space holder or something of that sort. And they come into you and you're like, we're going to do lower expander, upper expander, maybe some brackets on the front teeth to line things up. Do you face some resistance to that? Did you, and do you still? And how do you navigate that as you start going towards your treatment plan for this?
Yeah, there. I mean, there's definitely resistance to that. I think about it holistically, and what I mean by that, it's easiest when you start with the culture of your entire practice, which hopefully follows who you are, which, if you're doing this, probably does. What I mean by that is we make it commonly known we take a proactive approach. We try to do
Mhm.
everything we can in our practice proactively. We try to be great communicators. We try to get ahead of problems. So my team's amazing, by the way. They do like
Mhm.
95% of the explaining, and I do
Mhm.
5%. And
That's a
I'm
great
I'm
point. Yeah.
so fortunate to have that. It wouldn't be, I mean, I could do one or two patients a day fully educated if it was all by myself, but instead I do way
Mhm.
more than that because my team's so good at it. So you got to
Mhm.
set that bar where you go, all right, here's what we are. We are proactive. And then when parents come in, whoever they talk to is giving them that messaging that, hey, listen,
Mhm.
we do orthodontics a different way than many others do. Not judgment, just true. Okay.
Yep.
We prefer to take a proactive approach. If Dr. Leland sees an issue that's developing, if we're able to help it right now, we want to jump on it and fix it right now. Whereas the more traditional approach to orthodontics is to wait and watch a problem develop and get deeper and deeper. And then at the 11th hour, try to back our way out of this problem. And
Mhm.
that just isn't how we do things. Now, is that going to win over everybody? No. But I think when you explain it that way, many of the people that come in are going to look at that and go, well, that sounds good to me. And I'm
Mhm.
specifically talking about my daughter's health. Yeah, I'd prefer you take a proactive approach, not a reactive one.
Mhm.
So yeah, let me hear more. And
Mhm.
then the other big tip, I would say, like concrete tip, show people their kids CBCT.
Yes.
Have
Yes.
a monitor in the consult room where you're literally pointing to their CBCT, because when I'm doing expansion on a 7 or 8 year old, I mean, pretty much every time, like I said, a big reason for one of the main reasons for it is fit all the teeth in if we
Mhm.
reasonably can, which we often can at that age. Not always,
Mhm.
but most of the time. And they look at like upper 3, 4, 5, like the erupting canine and then the premolars coming in, and you point out the space available for those teeth to come in, and then you point
Mhm.
out how big those teeth are, and it
Mhm.
doesn't take an orthodontist to go, well, yeah, I mean, there's not even close to enough space. Then we go, all right, so that's what we're gonna do. We're gonna
Yep.
widen the arches. We're gonna make space. And oh, by the way, huge benefit of this is it widens the airway. And if they're having symptoms at that time, then that's all the more motivational. If they're not having symptoms at that time, but they really need this to fit the teeth in, then I'm a believer in it as well, because I think it's setting them
Mhm.
up for a lifetime of airway health, even if they don't have something going on right this minute.
Love it. Normalizing anatomy, and I tell people all the time, every patient isn't an airway patient. Like,
Absolutely.
so many people think like, "Oh, well, you see everything is airway." And no, no, but that doesn't mean we still don't normalize their anatomy. It's not like, "Oh, well, they're not mouth breathing, they're not snoring, they don't have these other issues, but we're just gonna let them go, and that patient can have premolars extracted or leave their arches narrow because they don't have a problem." You still try to normalize the anatomy. It's just in the patients who you also detect an airway problem in that can have a side benefit in helping them in that regard as well, which we'll get into more in a moment. The other thing I want to recognize that you said, which I love, and I probably don't, I definitely don't say enough, is team education. I was fortunate to have an awesome team as well. And man, they took so much of that. They just from the first phone call, right? They knew that patient was 6 years old or 7 years old. They knew exactly how to script it to them because I took the time to educate them on what we were doing, why we were doing it. My TCs, they understood this. So you have to have team members who understand your vision. You have to create the vision as the boss, and then you have to have team members who understand that. And I love how you said, it's just this is it. We take a proactive approach. We don't apologize for it. We don't criticize the guy or gal down the street who doesn't, but this is what Leland Orthodontics does. This is who we are. This is what Duluth Orthodontics does. It's who we are. And so I love that you referenced that. Also, showing them the cone beam. Such a great point. I say all the time to people, they get it. It doesn't take a rocket scientist to take, I call it my airway tour. We go in through the nose and then I go in through the mouth tour and you spin the skull. And it's not like, especially in today's 3D world, I mean, in virtual reality world, like it's not hard for people to conceptualize what's actually going on there. And patients and parents, especially who may initially even be skeptical of this early treatment or, I didn't get braces till I was 14 or 13, all of a sudden you see them start to look a little differently, right? They look at that image, that cone beam, and they're like, whoa, there's a lot going on up there. And I said, yeah, that's why we take this image. That's why we look at this. So on the airway note and cone beam note, what are you looking for? And how is that impacting your plan? And how are you working with, say, medical colleagues to get the patient the care that they need? What's your, just take us through maybe a 7-year-old patient comes in, narrow arches, constricted, crowding. Before you even get into the teeth and where they're at, what are you looking at? What are you looking for? And how do you go through that process?
Yeah, so I'm looking at anatomy and relating it to symptoms. And like we said, there's not always symptoms like airway related
Mhm.
symptoms, but my TC does a lot of the information gathering before I ever meet the patient. So she's asking
Mhm.
them, does your child snore? Do they mouth breathe? Do they drool on the
Mhm.
pillow? Do they have difficulty paying attention? Things like that. Assessing the situation, she knows what I want to know, what might be a trigger
Mhm.
for, ooh, this might be a narrow airway. And also talks to him about, hey, okay, what are you hoping to accomplish? What exactly are you here for? I mean, in nicer words than that, but then comes in and relays that to me. And while she's relaying that to me, I'm looking through the cone beam in my office. I personally think that's very important too, to do the initial diagnosis not in front of the patient, because
Yes.
when you're doing it not in front of the patient, you can ask real questions of your TC, like, Okay, are they really into this? Are they really seem open minded and excited about what we have to bring? Are they closed off? Are they defensive? And knowing that going in doesn't dictate my treatment, but it really helps me gear up to how to best relate to them and help them.
Yep.
Because ultimately, that's it. I use the phrase all the time, it matters way more how you make people feel than what you actually say or do. Okay. If you
Hmm.
say a bunch of scientific things that are all accurate, but you make them feel like this guy doesn't care about my daughter, then you're done.
Hmm.
If you
Hmm.
can communicate that you really care and they know they're not an orthodontist, they know you are, they want to trust you. They want to gain
Hmm.
trust in you. They don't want to understand the ins and outs of every little mechanical thing you're doing to their child. So anyway, getting back on track. So when I'm looking at the CBCT, I'm looking at the width of the maxillary mandibular arches. I'm measuring that objectively at the level of the sixes on the upper and lower. I'm
Hmm.
scrolling through coronal slices, like you said, of the nasal cavity and looking at basically how much space there is, how much width
Hmm.
there is. Also, getting an appreciation for the inclination of the maxillary mandibular teeth to try to
Yes.
appreciate, okay, if I'm not seeing a crossbite, I need more information to know if one or both of the jaws is narrow, right? Like you were
Hmm.
talking about, Mike. And I'm also looking at a sagittal slice, looking at the airway, looking at the adenoids, and also trying to get an idea of their tongue position. Now, it's just as
Mm.
CBCT is one snapshot in time, no doubt about it. You can't hang your hat on that, but you can get a pretty good idea if they have a lot of the time.
Yeah.
If they have a good tongue seal, good tongue position, versus if you see super narrow arches, you see their tongue nowhere near the palate in the
Hmm.
sagittal slice, and the kids snoring all the time and mouth breathing. Well, these things are adding up to, okay,
Yes.
narrow maxilla can't breathe through their nose, probably needs myofunctional therapy to teach them where to put their tongue once we get the space available. And it all adds up. Everything with airway is it's a sum of the parts. You can't just take
Hmm.
one piece of data and draw a conclusion off of it.
I love what you're saying because you're saying it so directly and succinctly and accurately and in a way that I know people can understand. And that's not always a strength of mine, is being quite as succinct in that way. And you hit it all. I mean, you're looking at this for the composite of symptoms in this big picture, right? There's no one thing that, I mean, I guess, if they have complete obstruction of the adenoids, right, or 90% obstruction, or turbinates that are so enlarged that maybe, but those are tend to be more the outliers. Most of it is this composite of symptoms that you're putting together. And you know something, Andrew, the thing about this, as you're saying this, and you're speaking exactly my language in this, is there are people out there, and this is not a criticism, it's just a fact, who don't want to take the time to do that. Their practice is very busy. They have a system down. They have a quick pan. There's a lot of colleagues, they're not even taking a sep. They're just taking a quick pan. They're looking in the kid's mouth real quick. And we know this because we get second opinions that come in and tell us time and time again, well, at the other place, doctor walked in the room and took one look at my son and said, you don't need anything yet, or 4 teeth out and braces, or whatever it might be. What you're doing takes a tremendous amount of time and energy, and not just doing it there for that exam, but all the time you spent educating your team, right? Investing in the technology, learning how to read that image, doing it in a system so that you're not in the clinic with a patient trying to do this at the same time, but you have the time to go look at that. We did ours in the records room, and my TC, I had a briefing. We had about a 3-4 minute briefing where she did all the data collection you just said, and we actually had a little form on an iPad she filled out. She came in, she went through it in order every time, same order, all those background questions with me as I'm looking at the cone beam and the pictures to start to put together, before I even walk into that room, a picture in my mind of what I'm dealing with here. And it also included, as you said, what's their overall attitude to treatment? Are they aware of this child's problems and so forth? So that's a lot of time. It's a lot of energy. It's a lot of work. And I think that's sometimes some of the resistance to people going down this path is they just maybe don't want to put that work in. And I'm not telling anybody they have to, as I've said often. Where I get frustrated is when people don't want to do it and then criticize others for doing it. That's where, again, that's where I have a hard time with it. But if you don't want to do that, and you want to practice the way you want to practice, I'm not here to tell you you can't or shouldn't. I think there's other ways to do it that are more beneficial to your patients and your community. The other thing I love is with the tongue, and that being just like a sign, right? It's not that you're looking at one thing like, oh, their tongue is not on the palate, or the tongue is pushed more posteriorly and their oropharynx is narrowing. As you said, the cone beam's a static image, right? It's not dice. You're not taking this dynamic image of them in their airway. but that doesn't mean it's irrelevant and that you can't glean certain insights from that image that you can then start to put together the pieces of this puzzle, right?
Absolutely. I think, I mean, to go a little bit existential on you, Mike,
Bring
um,
it. I love it.
humans like certainty, and they
Yeah.
like certainty now. And
Yep.
you want an answer now, especially our field. We're scientists, we're high achievers, we're people that get stuff done, right? And that's good. I love
Yeah.
that. I love our colleagues, by the way.
Mhm.
I'm all about orthodontics. I think it's great. So anything I say
Yep.
is not a shot at anybody at all. But
Same.
people want certainty, and we can get it in a lot of ways in our profession. But that's the one way that airway treatment I think is different than the conventional approach is you have to be okay sitting in uncertainty for a little while.
Mm.
Also, making a judgment when there's no exact clear judgment that can be made. It's like I have to extrapolate this a little bit, and I'm going to do
Yes.
what I think is right, and I'm not able to 100% guarantee you that I am right.
Right.
Take it or leave it.
Right. There's no molar classification analogous to airway,
No.
the symptoms of sleep disordered breathing, or again, that term, I know some people feel that puts more the emphasis on sleep than the breathing, but it's a common term that we all know. So it's a term that I use. You can't define it. It's not like, I mean, well, I shouldn't say. There's a definition, but you can't look at it. It's not like obstructive sleep apnea, the most extreme form of sleep disordered breathing, where there's a test for it, right? I think that's why we love to talk about OSA in the
Yeah.
literature and do they have OSA? Well, why? Because we can test for it. Now, whether or not that test is valid in children, whole nother conversation for a different episode. But the fact is we can test for it. And you're so right. We love that certainty. We love that comfortable little box. We can check, yes, they scored above a 0 for a child, or no, they didn't. But as I think about it more and more, I think, but just because they didn't score a 0 doesn't mean they're healthy. It doesn't mean that child has no symptoms. Sleep disordered breathing has a myriad of comorbidities, and it's our job to try to detect them, but it is more random, right? Like it's right. I mean, there's a randomness to it.
Well, and I have an opinion too. I feel like we're too far in our profession towards don't do treatment unless it's absolutely necessary. Now, I don't want that to be taken out of context. I have no
Mm.
intention of doing treatment on someone that I don't think I can provide benefit for. A lot of times I try not to do treatment because I don't want to put someone through that. But on the flip side, I think that we don't focus enough on what could be the benefit of doing treatment right now. You're right. There is some kind of a risk that they won't change much if we do this treatment. Okay,
Mhm.
acknowledged. But there's a very reasonable chance that we'll do significant benefit for them as well. And I
Mhm.
feel that if we educate the parents on this and say it just like that, say, you don't
Mhm.
have to do this, but I recommend it. If it was my son, I would do it. And because we might see a ton of benefit. I really think there's a good chance we will. And I personally think we can put that choice in their hands. It doesn't have to be the doctor coming in saying, this is the treatment plan, done, no choice.
Mhm.
I think we can walk people through it, give them the information, and as long as we present it that way, it's their choice. And if we treat them, that is a good and fair and virtuous thing to try to help people.
That's so well said. What would you say to those who are somewhat scared or intimidated? Maybe they're intimidated by their colleagues because their colleagues are throwing a lot of hate and there's a lot of hostility coming their way because they start to do some of this. And um, as I personally experienced, some colleagues don't like it when you're doing things a little differently and come after you for that. Or online, maybe they see people throwing a lot of shade on this and they're not comfortable going down that path, or they worry there's maybe liability, because I've heard people, thought leaders in our profession, talk about like, oh, if you go in earlier, there's the lawyers out there are going to start to get after this, and there's no precedent for it. Again, all not true, but people hear that and they get a little intimidated by that. So, what would be your advice to those colleagues of ours who are thinking about this or going down this path, but are just a little bit scared to do it?
I think we'd all agree that the guiding light of how we make treatment decisions as any kind of healthcare provider has got to be how can we help the patient the most? It's
Mm.
not am I going to get sued or not? It's not what I feel like doing. It's not how my practice runs well. And now I'm not saying that those things don't matter either. I'm not saying I don't think about those things. Of course I do. But the
Mhm.
guiding light's got to be, how can we help this patient the best? And that doesn't make it any less intimidating, but I do think that the group of airway focus, or we shouldn't even say people that are doing tons of airway treatment, but people whose minds are open to it. Like they're not going to just come after you if you talk about it. They're going to hear you out and have an honest, educated discussion where two people respect what each other is saying. I think that number is growing considerably. Now, I think it's at the level right now, if you look around any local community, there's probably some exceptions, but most local communities, yeah, you're not going to find many other airway focused orthodontists around. It's not that
Mhm.
pervasive yet. But if you look around the national community, the world community, you'll find plenty of like minded orthodontists and every other kind of practitioner whose mind's open to airway, who's supportive of helping people in this way. So I guess my advice would be, pick who your friends are a little bit. I mean, keep
Mhm.
an open mind, and definitely, I'm always in support of having a discussion with anybody who will have an honest, respectful discussion, regardless of what their beliefs are. That's what makes these new things come about. So we need that. But if
Mhm.
people, their whole purpose is to throw mud at something, I don't want to engage with those people. That's not worth my time. And then also going down this path, there are plenty of people to support you. Your whole community, your podcast, you're bringing these people together. The World Dental Sleep Society, I went to that first
Mm.
annual meeting
Mm.
recently. That was an amazing group of people. So there's plenty of support. You would not be the only one doing this, not even close. You can reach out to me anytime, and I'll do whatever I can to boost your spirits if they're getting down.
I appreciate that. And that's what I've noticed too in doing this is how many wonderful colleagues and supportive colleagues are there. Sadly, just the way social media is, it's not unique to our profession, that's for sure. But
Yeah.
the loud voices in the room tend to be the ones on the opposition side, the ones who are trying to throw that mud and throw that hate and shoot those arrows. But there's so many that aren't. And that's why I really appreciate you opening up on that and offering your own time to our colleagues because I get so much feedback from people who are in that position where they just don't know. They just don't know. And maybe they're afraid of failure. And we can talk about that side a little bit too, but they don't want, we're perfectionists, orthodontists and dentists in general. And we like to be in control. And there is a little bit, I can say from taking this leap myself many years back, I still remember. I mean, we're going back decades ago now, but I remember that feeling of like giving up a little of the control to start doing some of this. Things get a little more chaotic at first. You don't have your systems quite down, and it's not easy. That being said, once you start doing it and you start doing, and what I love that you said of put the patient first, right? Patient centered treatment. Do what's right for the patient. Well, then it doesn't matter what age you're starting or whether you're using this type of technique or this type of technique. You do what works for you, but just keep the patient's best interest in mind. And the rest takes care of itself. And then you start to see the rewards of it. I had someone reach out to me just recently telling me a story about a tremendous impact they had on the life of a young patient because of something they caught on cone beam that no one else had, taken the cone beam or figured out on this kid. And mom's in tears. And so once you experience that, like, I don't know. To me, it's just like, what's more rewarding than that in a day, right?
Absolutely. And I think to add to that too, like it's advice wise of people thinking about this, don't operate out of fear.
Mm.
Assess risk. We tend to assess risk based on only what could go wrong. But risk has two sides. It has what could go wrong and it has what could go right. It could have, in
Mm.
this case, how much more benefit could we bring to the patients if we start doing this treatment the right way, in an educated way, to only the patients who need it. But what benefit could we bring? And I think that when we operate out of fear, it's the easiest thing to do is not change.
Mm.
But think about, I know everybody in our shoes is going to agree, or at least most everybody, that they really genuinely want to do what's best for the patient.
Mhm.
So from that regard, think about the potential benefit these kind of treatments could bring and definitely weigh that equally into the decision against the downsides.
Well said. Switching gears a little bit, but staying in the kind of the mindset and failure side of things, because those are a constant underlying current and theme in all of this. Amanda Vanderstelt was on recently, and we talked. I've had multiple guests on where we've talked about the challenges with female guests of being a mom, a wife, a business owner, and an orthodontist. Haven't had that discussion as much with dads. Trevor Nichols and I got into that a little bit, but I'd love to hear some of your thoughts. Being all four of those things, you've got three little guys, right?
Yep. Yep.
Yeah. So talk about that challenge. How do you balance it all? Because that's another thing that it's real for dads too. Like, I mean, especially if you have a spouse that's in the workforce, and I mean, there's a lot. Your kids are so busy today, and as they get a little older, they're involved in all these activities, and there's just so much going on. So how do you feel you're striking that balance? And if not, where do you feel like you're falling short in that? And how do you strike the balance that you have?
That's a good question too, and it's a constant struggle. I mean, on one hand, I want to spend a ton of time with my kids and bond with them and create a great bond for the rest of our lives together. But at the same time, it means a lot for them to see me grind and try to achieve my dreams and have goals and
Mhm.
take risks and be vulnerable. I want them to see that. I believe that they'll value that. Maybe not now because the oldest one's 11. So
What are their ages? What are the three ages?
11, 8, and 6, and I have three boys. So it's WrestleMania slash what football or hockey game are we watching now? Which I love. I'm all about it. But I mean, first of all, I'm fortunate to have an amazing wife who is incredibly supportive and basically is like, hey, listen, the practice that we're both creating, because she does a ton for the practice. She's worked in it at times. That was never fully the design, but we needed her for one
Yeah.
reason or another. And she stepped in and learned,
Yep.
basically took over a various TC role, kind of office manager
Mhm.
role on a whim when she's not in dental. So she figured it out. And man, that was tough for her. And I appreciate and love her so much for it. But also outside the office, she's doing things behind the scenes, running spreadsheets, all this stuff. So I have that support. That's amazing. And that enables me to be at the office when I need to be. But one thing I will speak on is the mental and emotional energy component, because I've had a switch in that. When I was trying to do everything at the office, I would still, I've never had to spend hours and hours there, but honestly, my mind would still be occupied a lot of the time at home. One of my
Mhm.
goals for this year is just whenever I'm home, whenever I'm with my family, is be mentally and emotionally present as much as I can. It's not going to be perfect, but I want to be conscious of that and aware of that. And that was not so good, I would say, the first 4 or 5 years. So, most of my practice life so far. I mean, I was
Mhm.
playing the role of doctor and of business owner and of leader and of key message deliverer to the team and orderer a lot of the time. And since then, I've taken not a different approach to my team, but just trying to empower them as much as possible. And
Mhm.
so far, they've really picked it up in spades, and I'm just so grateful to them. Like I said, I have an amazing team. Recently, I got a director of operations, which is like an office manager,
Mhm.
but one level up. And he hasn't been with me that long, but he's been doing some amazing work as well to take work off my plate. And the reason that plays into all of this is when I show up back at home, I'm much more present mentally and
Mhm.
emotionally. And I feel like that's valuable with my family. But that, for me, that was the biggest challenge. It's not specifically hours in the day, but mental and emotional ability to engage when I'm home.
That's such a common problem. Man, and this is what's so much fun about doing this. As you're speaking, I mean, you and I have talked a little bit before this, getting to know one another a little, but not on this level. And what you're saying is like it's like a carbon copy of, of my experiences in my trajectory through practice and overdoing it, taking too much on. And then even when I started to delegate, I'm thinking about it when I'm not there doing it. And the role my wife played, stepping in from not being in the dental profession, and the spreadsheets, which she is very well known for her tremendous ability with spreadsheets, but
So is
helping out,
mine.
running the front end. Isn't that,
Yeah.
they got to meet.
It's amazing.
It,
Yeah.
we would joke with, if there was a problem in the office or a system, Renee had a spreadsheet to fix it.
Yeah.
And so it's just so similar. And that creates, it's wonderful. It helped our relationship grow in ways, but it also challenged it,
Oh, yeah.
right? Like you're talking about, when you're home, you're always talking about work. And if there's a team member that you're having a challenge with, or a new tech, whatever it is. And so I think a lot of us go through that too. And I'm really glad you brought that up, because it can't just be you and I. And there's other people I speak with who I know their spouses get involved in it, and there's wonderful parts of that, and there's challenging parts of that. And so it can go either way. And I think that open communication and being able to have a shared vision as a family, and also I think knowing when to say when. One mistake I made is us type A's, A pluses, we don't always know when to say when. And I give you a lot of credit for right now saying, okay, I need to make this a goal for this year to be a little more present and focused. So often I think that almost doesn't happen until it's too late, or until we look reflectively like, man, I wish I only had thought that. So you're still in the middle of it, and able to recognize that, which is really great. And as you said, it won't be perfect. There's going to be good weeks and bad weeks, good days and bad days. But the fact that you're conscious of that, I think, is something that's really important. And tying into something we started talking about, you run the show. And that's something I think I forgot sometimes. Like, it, you can just, if you need to start later one day or take an extra week in the year. I always struggled with that. I always felt like I needed to keep pushing. And it wasn't about the money. The practice was doing very, very well. It was just more kind of my own in my own head on it. I think a lot of us feel that. And that tends to be, it's a blessing in ways, because that's why we get to where we get, but it can be a bit of a curse in that regard too. So I don't know if you agree with that, but that's something that's a hard balance. At least I know it was for me.
It is hard. Yeah, and I do agree with that. And I experience like well, first of all, your role in the practice has to change dramatically as the practice grows. And you've said that
Mm-hmm.
in different words, I think. And that's one of the biggest challenges is not just who you are as a practice owner, it's who are you today? Because then a
Yeah.
year from now, if you want to keep growing, your role better be different. But you have to consciously make it different, or else you're pretty much going to stay where you are. Which, if you want to stay where you are, then that's perfect. Then there's nothing wrong with
Mm-hmm.
that. That's a choice. But I always want
Mm-hmm.
to grow. That's it. That's a core tenet of what I'm doing. And that's how it goes. And I struggle with what you were saying too. It's really important to me to be fair to people and to be equitable to people. And
Mm-hmm.
so I did have those feelings of like many times, well, my team members, they have to work right now. I should be there too. And
Mm-hmm.
I've since flipped that over and been like, okay, but you're not thinking about the conferences that you go to for a whole weekend. You're not thinking about the decade you spent in dental school and residency studying Monday through Sunday over and over again. You're not thinking about what you do right now. I mean, sometimes
Mm-hmm.
late nights where I got to figure something out for the business. So
Mm-hmm.
I'm grasping now. It's different. My role is different. And I can still be fair and equitable, even if I'm not coming in all the hours they are. That's how it should be. And if I'm mentally happy and my cup is full, to use a common term, I'm going to show up
Mm-hmm.
better for them. They're going to like it more. So that's where I'm at. But it's a constant learning process. I'm definitely learning every day.
Yeah, and that's the key, really, is that you're learning every day, and I don't think we can expect much more than that. That's the ultimate out of ourselves, right? Is to understand where we messed up, understand where we're doing it well,
Yeah.
take pride in the latter and work on the former, and take ownership of it and try to show up better. And that's something I can speak to too. Is when you do keep overworking and doing it and going down that path, you end up not showing up to be as the person you want to be for your team and for your patients, and we all think we can put the act on, but at the end of the day, people get to know us and they get to know, and then you're not who you want to be when you go home. So it is this sort of vicious cycle that people who are so driven to succeed, however we each define it, it can be a bit of a blessing and a curse. And that struggle of finding that balance, it's nice to hear someone else say to our colleagues, that's part of it. Right? Like,
Well, and I think that's just it. The balance is everything in life. There's nothing where you want to be at zero. There's nothing where you want to be at 100. And it's just finding where that right balance is for you. Because you're right. What got us here to be orthodontists, to be practice owners, to be able to serve a bunch of people is that type A ness. I mean, there's
yeah,
for every single one of us, there's periods in life where we had to grind. I mean, you don't have a choice. You got to do it
yeah,
now, and you got to work really hard. And we all did that. But again, like times change and you can't do that forever. But the difficult part is recognizing that in your own mind that, like, okay, I had to do that then. I don't have to do that now. I'm allowed to like enjoy life a little bit.
yeah. Smell the roses. I say it all the time. Like, it's a big challenge for type A plusers to stop and smell the roses.
Yeah.
It's like, yeah, I accomplished that, but yeah, that I should have, of course. It's not that you take it for granted, but you just think, well, yeah, okay, now next up, like, next challenge, let's go. I got that one done, and it's important, no matter how driven you are, to realize that The time with your kids, you don't get back. The time with your significant other, spouse, you don't get back. The time in your health, right? Fitness, we didn't even get into that part of it, but that side, you don't get that back. And if you keep compromising that, there's eventually a price to pay. And maybe you're, like you said, maybe you're okay with that price, but I think most of us want to have a lifespan and a health span that is significant. And if you don't take those steps when you're younger, I know we have a lot of different age colleagues that listen to this, but a lot of young docs especially. And I get asked a lot of these questions often. So I really appreciate you being open and honest on that, and that being that struggle, because I know that will help seeing someone who's in your position, who's succeeding, who's doing it, especially in a male role, because I've had a lot of female guests on who have been able to articulate that. But to hear that from someone like yourself, I appreciate that.
Yeah, absolutely. And one other note on that about perfectionism. I'm a self-labeled reforming perfectionist. And
Always, right?
I just figure I'll say this to this group of people in particular. Perfectionism is bad. Okay? It's not pseudo bad. Like, oh yeah, it's so bad. And in the back of your mind you're like, yeah, it's awesome. That's why I am who
Mhm.
I am. It's not good. It's not good. I've been a perfectionist my whole life, but I'm reforming right now. And
Mhm.
it's not like you flip a switch. It's not like you go from perfectionist to like anti-perfectionist, but
Mm.
in order to grow personally, in order to be happier, and in order to serve more people, honestly, that's what it's about for me at this point, is finding ways to serve more people. You got to let go of control. You got to let go of that extreme level of perfectionism. That can be managed when you're going through school, because all you got to do
Mhm.
is manage yourself. And
Mhm. Such a good point.
all of us are high performers. So although it's difficult, because yeah, you have to perform at a super high level all the time, you can do it. But
Mhm.
if you're trying to really grow, you can't do it, because it takes other people, and you have to let them operate how they're going to operate. And when you do that, I've found a lot of times they do it better than I would have done it. So it's not
Mhm.
only okay, it's a net positive, but it's a
Yep.
hard thing to jump over for any perfectionist to go, all right, it's okay if it's not perfect anymore. Not how I've lived my life up until this point, but listen, we're turning the dial down a little bit.
Yeah, because it's not just your how you're wired, it's all the years of experiences where it worked, right? Like
Right.
that's how we did succeed at school, to the point that we were able to push to that next level as perfectionists. And then it's really hard to get out there and be like, well, like now I can turn that dial down a little bit. It is so much harder to do than it would seem to be able to do, but it's really challenging.
I just think it all relates to, Mike, like everything we're talking about as far as going through school, growing in orthodontic practice. You need a mindset switch. Going through
Mhm.
school, learning the traditional methods of how to treat orthodontic patients, and then moving to an airway focused approach. It requires a mindset shift. Managing only yourself, and then turning over to own a practice, manage a team, manage a family, manage may not be the right term, lead a family, let's say,
Mhm.
mindset shift. I'm a big proponent of reflection, and you have to be cognizant of where you were and where you are and where you want to go. And as hard as it might be, try to make those changes to act appropriately, which is probably going to be different now than it was to get you here.
I love it. I'm gonna let you have the last word on that. That was outstanding. I really enjoyed this conversation, and just so many pearls. And as I said, you've got an amazing ability to say things very succinctly and directly, but be very profound
Oh,
in what you're saying. So I give you a ton of credit and really acknowledge you for all you're doing. You're a real leader in this profession. I mean that, and I hope a lot of people will hear this to be able to get to know you and meet you, because you really are someone they should look up to and emulate, in terms of not just what you're doing as a clinician and moving outside the paradigm and the dogmas, but your ability to try to do that while being a really good person, and a good dad and husband and business owner and ethical human as well. So I really value that.
thank you, Mike. That's an amazing series of compliments there. I really do. I really do appreciate that. I want to say right back at you, thank you for what you're doing to this, for this profession and for our whole airway community, which obviously goes way outside of orthodontics, is, you know, putting yourself out there, knowing you're going to, as you always
Yeah.
say, take arrows. And someone has to do that, and we all benefit from it. So that's acknowledged, and thank you. And let's go down this road together.
I appreciate the kind words, as well, and completely. This is what makes this fun: is meeting people such as yourself and being able to realize that we're in this together. We're in this together, and we really can enact change in our profession and anything we want to do based on our mindset, right? And that's all it takes. So really, really, really appreciate it. Dr. Andrew Leland, if you could, I know you mentioned people could reach out to you directly. How did they get in touch with you if they want to learn more about you? Is there any way I could put in the show notes for people to be able to reach out to you directly?
Yeah, absolutely. Email or call or text me. Email address at work is Dr. Leland, DRLELAND, at lelandorthodontics.com. And so I'll just give you my cell phone number, 206-718-4514. Anybody, contact me anytime.
That's very generous of you, very kind of you to put that out there. And I'll add that to the show notes as well. So I really enjoyed this. Thanks so much. I really appreciate your time and coming on.
Yeah, me too. Thanks so much, Mike.
All right. Take care.
All right. Bye.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.